One of them.
The best that I can. But one of the most prominent in Spain, probably, and also a very polyphacetic researcher. Currently is the PI of the molecular imaging group in Vall, and has a lot of very interesting research lines in different topics. And I think one of my favorites is the topic that I think we will be discussing today, that is related with insulin resistance and type 2 diabetes and the consequences for the brain. I'm particularly interested in this because it may have a potential relation with the FTG uptake, and I think it will be a bit also outside of the brain, but very, very interesting. He's also a great friend.
Yeah.
And years, one of my favorite persons to discuss science with. So, Raúl.
Okay, thank you very much, Jesus, and the rest of the people here, okay, Fundación CIEN, to invite me in order to show one of my research lines, because as Jesus said, I have all different research lines. But today I'm going to talk about brain insulin resistance in type 2 diabetes, okay? That some people working in diabetes understand that Alzheimer is like a type 3 diabetes. It's a new concept. Well, this concept was placed 10 years ago, okay? And daily, the people that is managing people with diabetes and also with an Alzheimer, this term is getting more importance, okay? The outline of my presentation is this, okay? I'm going to initially to introduce you a little bit on the context of type 2 diabetes and insulin resistance and Alzheimer's disease. Later, I'm going to give you the hypothesis that we have been in this study, okay? Why we have done this study. The methodology, because here the most important point is the methodology that we use for obtain these results. And then I'm going to talk about the phenotyping, the brain phenotyping of type 2 diabetes patient, where I'm going to show you two main phenotypes of patients, one with more cognitive decline risk and the other with less. And finally, I'm going to talk about the heart-brain axis and the liver-brain axis in terms of insulin resistance, in order to show you that all the happen in the brain occur in other organs. And then you need to see this neurological disease not only in the brain, also is a whole body problem. And finally, I'm going to provide a conclusion about the study that we have been performed. Let's talk about context, okay? Type 2 diabetes is like a pandemic. A lot of people talk type 2 diabetes the 21st century pandemic. Basically, it's a pathology, it's a metabolic disorder that the problem is the body don't respond or produce enough insulin to get the glucose by the cells. One of the diabetes problem is type 2 diabetes. That the problem of the type 2 diabetes is the insulin resistance. What is insulin resistant? Insulin resistant is the problem of the insulin to introduce glucose in cells. This is the burden of type 2 diabetes worldwide. Is 1 of 11 people suffer from diabetes in the world. 90% of these people is type 2 diabetes. Then is on a global incidence. This pathology, despite don't kill, is a long-term mortality, produce a long-term mortality in different aspects. It's an exponential growth each year. It's a risk factor of several pathologies. Pathologies in the brain, in the liver, in the heart, in all the organs in our body. What is the problem of the type 2 diabetes? It's the high content of glucose in the blood. Then this the high content of glucose cause micro and macrovascular problems. And these vascular problems trigger different pathology. For example, in the case of the microvascular complication, nephropathy, retinopathy, neuropathies, and also on macrovascular level, we have a stroke, peripheral vascular disease, and heart attack, blah, blah, blah. Okay? Then the diabetes is a growing problem in our society. What is the main problems, as I commented you before, of the type 2 diabetes is the insulin resistance. Why insulin resistance? What happened with the insulin resistance? Here, okay, the insulin resistance or diabetes is caused by our bad habits. Is sedentaries, bad food, unhealthy drinks, smoking. The bad attitudes and habits for an unhealthy life cause this type 2 diabetes, cause insulin resistance. As you can see here, okay, this is an abnormal body, okay? When you have glucose, the pancreas release insulin, and then this insulin cause the uptake of the glucose in the different organs. What happens in the insulin-resistant situations? The insulin can cause the uptake of glucose in all these organs. What consequence we have? All these consequences. We have problems in the brain and in different parts of the body, as I commented you before. Despite this problem, all the studies performed until nowadays are on a whole and systemic level. But what happened? That sometimes the problem in the whole body is different from a specific organ or tissue. Then is an unmet need the specific diagnosis of the insulin resistance in these organs in order to study them more precisely. Regarding the risk factor of dementia, there are a lot of risk factors that cause dementia. And as you can see here, okay, also bad habits. And then diabetes is a main risk factor of dementia. Dementia, you know more about dementia than myself, okay? But this is a definition of dementia that you can to find in everywhere. And basically is the progressive and acquired decline in multiple cognitive domains that cannot be explained by normal aging or delirium. This is an explanation that you can meet in different papers, in different places, okay? And this is a big problem, as you know, because it's growing annually, similar to the type 2 diabetes. Then, if we take into account all this type of dementia, this growing, where Alzheimer's disease is the main dementia that you can see in this slide, and also the problems caused by the 2 diabetes, then we have just now about 2 pandemics in the world, the Alzheimer and the type 2 diabetes. But what happened with the Alzheimer's disease? This is another definition. I'm not going to read this definition because you know more in detail about Alzheimer than myself. But in this decline, okay, you have a different problematic in the brain of the Alzheimer's disease, as is the accumulation of the beta amyloid, the neurofibrins go inside the neurons and cause different problems. There is a degeneration of the normal synaptic process in the neurons, and this is a big problem. There are a lot of efforts in order to understand better this process and to combat this pathology, but until now, I don't know exactly, because you have more idea about the different treatments about Alzheimer's disease, but just now, the people don't have a treatment and a proper treatment for this disease, and it's caused in the neurons. regarding how type 2 diabetes can trigger Alzheimer, because as you know, no, in the initial slide, sorry, I said that type 2 diabetes, okay, is like a pandemic, like an Alzheimer disease. And the people that has type 2 diabetes, it has around threefold more probabilities of suffer Alzheimer than the normal people population. Then why this happen? Because the diabetes and the obese people, okay, is observed by a high content of glucose, that this hyperglycemia is glucosylate different proteins in the body. Also, these people has a lot of dyslipemia, is the release of fatty acids in the bloodstream. What happened? All these things can cross the BBB and then generate a pro-inflammatory state in the brain, and this pro-inflammatory state in the brain generate a neuronal insulin resistant reticular stress and synaptic failure of the different neurons. This is known as, this is all related to the Alzheimer's disease. Moreover, the characteristics of the type 2 diabetes is oxidative stress is also present in Alzheimer's disease, where these ROS species can generate bad monomers of this type of fibrils, advanced glycylation end products, that like here, okay, and then these advanced glycosylate products can affect to the, I don't remember never, the tingles, no, the tangles. Also, the type 2 diabetes has an inflammation, and this inflammation also is present in the brain of this type 2 diabetes in the Alzheimer's disease patients. And also, the patients with type 2 diabetes suffer for autophagic dysfunction. This autophagic dysfunction can affect to the elimination of the beta amyloid in the brain, and also suffer from these oligomers. Then there are a good connection between the type 2 diabetes and Alzheimer's disease catalyzed by the insulin resistance. What is known in insulin resistant in Alzheimer patients? Pues the insulin resistant generates a desactivation of the AKT, then this AKT, this kinase is don't regulate, then is upregulate the GCK3 beta, that is very related with the dementia, and then start the tau hyperphosphorylation of the neurophilic tangles, and then generate the neurodegeneration. Other possible via is the hyperinsulinemia, because these patients, how they can to uptake the glucose, the pancreas release a lot of insulin, because the cells send this signal. I need insulin because you have blood, but I need to obtain this blood. Then the body of a type 2 diabetes patient release a lot of insulin. Then this hyperinsulinemia secretate the degradation of the enzymes, and then there are a decrease in the clearance of the beta amyloid plaque. All this is related to the neurodegeneration. Again, okay, the type 2 diabetes is insulin resistant, cover the impairment of insulin signaling, vascular damage, neuroinflammation, tau hyperphosphorylation, and accumulation of the beta amyloid, all related with the neurodegeneration related to the Alzheimer's disease. Then, insulin resistance is one of the pathological mechanisms in the brain that can suffer the Alzheimer's patients, and more the type 2 diabetes patient. This is an hypothesis, it's the same graph, I think, but the peripheral insulin resistance, that is well known in type 2 diabetes patients that suffer from lipotoxicity, glycotoxicity, inflammation. This also is shown in the brain of the Alzheimer's disease patients, where you have an activation of the glial activation, and an acetylcholine impairment, beta amyloid, tauopathias, blah, 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 blah. And there is the people in the literature said that maybe the driver of everything is the mitochondrial diffusion and then the oxidative stress. In fact, the aging causes oxidative stress, and any metabolic disorder causes oxidative stress, and inflammation is cause oxidative stress, then una mitochondrial dysfunction, and then as either inflammation and metabolic disorders alter the insulin pathways, and then cause a protein misfolding, no? That is shown in Alzheimer's disease, but also in type 2 diabetes. And then what is, since the systemic insulin resistance sometimes don't correlate with the organ-specific insulin resistance. For example, we performed previous studies that I'm going to show you in the myocardium, but also in eyes, in type 2 diabetes population. Sometimes the systemic index of insulin resistance don't associate with the pathology in this organ. However, when the people is died and we obtain these organs and then perform an histological analysis, in these organs don't have insulin resistance. Maybe in other organs, then it's mandatory to phenotyping patients in order to do a more personalized patient management. Then our hypothesis that we generate is, okay, this is our hypothesis, taking into account type 2 diabetes, the problems, the Alzheimer's, the insulin resistance, everything involved in the similar. Then our hypothesis was that if we perform PET-FDG, FDG, PET-CT imaging, we can have the chance to determine the organ-specific insulin resistance in patients to evaluate potential comorbidities. Moreover, since the methodology that we generate to obtain this phenotyping is very complicated, is not very useful for a clinical assessment, daily clinical assessment, then our other idea, other hypothesis is if we use this image together with omics data and biochemical data, maybe we have the opportunity to develop mathematical functions to detect patients, and also with this biomarker we can to manage the patients, to manage the patients. Then this is the idea over our study. What is the methodology that I say that it's not simple? Okay, in our study we perform initially a PET-CT of a patient in a baseline status. After 2 days, the patient come to our nuclear medicine service, and then initially we collect blood to obtain to perform biochemistry and metabolomics and other types of analysis. Later, we perform an hyperinsulinic euglycemic clamp in the patient. What means this? This is to perform a pancreas, a synthetic pancreas. We avoid the problems of the pancreas. We perform all the insulin that a patient needs in order to uptake the glucose in the body, and then we eliminate the problem that the pancreas can cause in our signals. Later, we administer the FDG and perform a second scan. Then, taking into account this image and this image, the rest of this image, this is the clamp sub, with the baseline is the insulin sensibility in this organ. That is contrary to the insulin resistance. Then this technique we have been used in order to determine the organ-specific insulin resistance. That is our focus. Our focus just now is to phenotype patients of type 2 diabetes in all these organs in order to build up a mathematical function to manage type 2 diabetes patient from the personalized manner. With this system, okay, in the bibliography, you can find other approaches in order to determine insulin resistance. Basically, it's a dynamic scan, FDG scan. Then you can to determine the constant that this glucose is uptake in the organ. And some people have do this approach of approaching this constant to the insulin resistance. But what happened? For doing this type of study, you need controls. In this case, each patient is the control. The baseline condition of the patient is the own control of the patient. Moreover, here we eliminate, since the own patient is on the control, we eliminate or reduce any alteration caused by drugs, diet, exercise. We are working with FDG. So all these parameters can affect a lot to the uptake of this glucose. And then this is our goal for the last 7-8 years. We are working on that. In fact, just now we have around 85 patients. It's not easy because this is only in research. Doing 2 PETs in the same patient is not simple, despite we inject the half of a dose in each scan. In order for radiation protection, we have only 1 dose of radioactivity. Yes, but in the end, you need to do that. Okay, this is the scheme. This is simple, that we are following patients constantly. The inclusion-exclusion criteria that we have been performed is we need patients with at least 5 years of type 2 diabetes, with a control of these conditions at least 1 year. And the age is very broad, okay, because it's not easy to find this type of patient for doing these approaches. As exclusion criteria is, of course, type 2 diabetes, any previous cardiovascular event that can alter the study, claustrophobia. We need more life expectancy than 1 year because these patients are following in the clinical daily practicing. Also, we would like to remove alcohol drinkers or smokers. And also, this is also mandatory that the score of the medimental state of these patients is higher than the score 25, initially without dementia. The result of the brain phenotypes that I'm going to now to introduce you, this result has been published by us in Brain Communications last year. And basically, in these patients, we performed two approaches. One is to raise the baseline signal to the clamp signal in order to determine the hypometabolic regions in the brain, or to raise the clamp signal to the baseline in order to obtain the hypermetabolic. This is related with insulin resistance, and this is related with insulin sensibility. After doing this experiment using the ISPM approach, we determine all the regions affected in the brain of a type 2 diabetes patient. As you can see here, all the regions also are defined in Alzheimer patients. In Alzheimer patients. But basically, in the cortex, in the vermis, in the cortex, in the limbic, and the cerebellum. Because the cerebellum in the type 2 diabetes patient is not a reference site, because they cause an atrophy. This metabolic disease causes an atrophy in this type of patient. Then there are some people that sometimes use the cerebellum as a reference site for studies, but in type 2 diabetes patient, you cannot use it. Then here is a clear example that this region is affected by for not getting it as a reference site. Okay, then This is simple. We have in the cortex 3 insulin-resistant regions, and we have 6 insulin sensitivity regions. Once we have determined this part in the brain affected, we would like to know if these regions are connected between them. The first approach was to connect if there are any connection between the hypermetabolic and the hypometabolic region. We haven't found this association. However, within the same group, we observe that the hypometabolics and the hypermetabolic regions separately, they have an association, and then between all these regions associated, we determine that the more critical insulin resistant and insulin sensitivity regions of these patients was in the cortex, in the gyrus, that is a region very affected in Alzheimer's patients, and also the vermis, in the cerebellum. Moreover, since this region was the most strongest association with the rest of the clusters, we check if this cluster also were related to the OMA. OMA is a systemic index used in the clinics in order to determine insulin resistance, and we observe that this region, if you use OMA to assess these regions and to manage patients, it's not, at least in this core, it's not a good biomarker. However, the CLAM, that you have information of the real sensitivity of the insulin of your organ, it was very clear that the association was very, very good. But what happened? We can't do hyperinsulinemic glucemic clamp to all the patients, because in fact, one patient spent between 3-4 hours with an insulin and a glucose infusion. Then it's not useful for the clinical assistant. However, this analysis provide us with very nice information that this cluster are related with the insulin sensitivity in patients. Then what happened? Then, since this was the 2 regions more important in the brain of our patients, we perform a draw of our patients, taking into account the signal, the hypo and the hyper signal. And what we observe? We observe clearly 2 types of phenotypes in these patients. One, we say with insulin resistant and with insulin sensitivity, hypermetabolic regions and with hypermetabolic. It's like the patient has in the brain a hypermetabolic region that sometimes when we need to follow these patients, when along the time, these hypermetabolic regions is transformed in hypometabolic regions, and then start a decline maybe in this patient. Then taking into account these two clusters, these 2 phenotypes of patients, we determine what happened in these patients, what is the difference in terms of biochemical difference of these patients. We observe that the distribution of the erythrocytes were different. In fact, in the literature, if you read the literature, some people say that erythrocytes the formation of these erythrocytes are very connected with the Alzheimer's disease. There are a lot of publications. This is a simple test, is to show the shape of these erythrocytes. What happened? Again, another transferasa, the alaminotransferasa, also is affected in these patients. This said us that these patients maybe are metabolic more affected than the other group. And what we observe, this is the more clear. This is a protein that have been also described in the literature for Parkinson's disease, for Alzheimer's disease, for these cognitive declines, that is, I don't remember here, secreted Fritz-led related protein 1. And we observe that this phenotype of patients has the double of this protein that the other group of patients. Then also, again, we classify this phenotype of patients as a risk factor of developing cognitive decline. They have more insulin resistance, and they have more inflammation, because you can see interleukin 6, okay, this patient has more inflammation. Then, that way, we identify for the first time two phenotypes of patients in terms of brain insulin resistance. One with a lot of cognitive decline markers, and the other with less. Then I would like to also, I have plasma of these patients in order to know more in detail what happened with this phenotype. Okay, then is okay. Later in the 9 regions affected for the hypo and hypermetabolic, we determine if there are differences between both phenotypes, and you can see here in all the hyper and hypometabolic regions there are differences, and a clear differences between the two phenotypes that we determine in terms of brain glucose brain uptake. But this is okay. We have just now we identified these phenotypes. They have risk possibilities, but our goal is to identify this patient simply by a biochemical analysis in order to transfer all our knowledge to the clinical practice for managing this pathology. What we observe, we develop different linear functions, very simple, with a very exciting results. We develop 3. One, this is more complicated because it has the insulin sensitivity. You need to perform hyperinsulinemic clamp in the patients. Then this is for research purposes. We develop another that also here you have the OMA, and in primary care the insulin usually is not determined. Then also is in tertiary hospitals where sometimes the physicians request this value, the insulin, then they can to use this function. But this is the most simple one. It's based on procollagen, the distribution of erythrocytes, and the content of aminotransferase. And this is a very simple equations. Then, after having these equations, we would like to analyze in a epidemiological point of view, okay, with retrospective data, if this is a real equation for managing Alzheimer in type 2 diabetes patient for the population. Why? Because it's a pandemic, the type 2 diabetes. As a summary of this part, this is the main summary. We have been the first group that we determined the existence of the hypo and hypermetabolic glucose patterns in the brain region of patients with type 2 diabetes. We determined 2 phenotypes using the FDG, being the right superior temporal gyrus and the cerebral vermis, the most important regions in the brain to manage these patients, to manage type 2 diabetes patients, to check the cognitive decline. We also observe as the for transferring from one phenotype to the other is changing only the metabolism of the glucose in the brain mediated by the insulin. The altered parameters that I show you are no, bueno, this is basically the equations that I show you. Okay, we have been the chance to develop equations to manage this patient easily in the clinics, and we think that the phenotyping implementation into clinical practice could contribute to the future personalized treatment strategies in cognitive decline risk prevention in type 2 diabetes. Okay. However, if you can see here, okay, we observe that we have here alteration of the amines, transaminasas related with the liver. Then we observe and then we say, okay, maybe this brain is connected with other part of the body. Then the most known connection in the brain is the heart. In fact, here in Madrid, there are a large study in the CIEN, okay, that they connect all the cardiac pathology with the brain pathologies. Then at that way we say, okay, but let's to study what happened in terms of insulin resistance with in terms of the brain-heart axis. This is a previous publication that I don't provide you with the publication, but I think this is Journal Personal and Medicine. I don't remember exactly. This paper has around 6 years. We was doing a large clinical trial in order to obtain biomarkers for the prevention of the stroke, and we observed in type 2 diabetes patient a strange behavior that when this patient has a baseline, the myocardium don't uptake glucose. However, after clamp, we have the half of the patients that have an uptake, and the other no. Then we classify these patients as insulin sensitivity patients, and the other as an myocardial insulin resistant patients. After studying this type of patient, we observe that the resistant phenotype has a lot of calcifications in the arteries and also lipomatosis. That is a reduction in the radiodensity of the myocardium. All components related with the cardiovascular risk. Okay, we have two phenotypes in the heart, two phenotypes in the brain. What happens if we perform? Let's study the relationship between the brain and the heart in terms of insulin resistance. What happened here? No? It's so strange. The first that we performed was a simple analysis. We measure the uptake of the glucose in the brain with the uptake in the heart. And we observe an association between what happened in the brain with the myocardium. Also, when we split these patients by the patients with the phenotype, the brain phenotype of risk or no risk, we observe a different behavior with the heart uptake of glucose. Then they say us that this connection exists. So what happened then is, okay, let's split this patient by phenotypes, and let's check what happened if I split this patient by the myocardium phenotype. What happened with the sub in the brain? Oh, curiously, it's different also. What happened in the heart if we separate with the brain phenotypes? Oh, again, we can separate these patients. Then this demonstrates that this connection in terms of insulin resistance exists. Then we move on, and we check what was the cardiovascular risk factor of any of our brain phenotypes. And then about all these indicators, we have the Framingham score. This score is used for cardiologists to determine the cardiovascular risk in patients. Then, if we split the patients by the brain phenotypes, we found this the score meets these differences between both phenotypes. Also, the epicardial adipose tissue is the fat that covers the myocardium. The cardiologist, when you have more fat covering this myocardium, you have more risk of suffering a heart attack or other vascular problems. But the patient phenotyping by the brain happened this. But let's check what happened in the other way. Okay, when we split the patient by the myocardial phenotype, we observe also a little bit differences again in this protein. This is more, we have here, well, but we have 42 patients, 42. But we also observe differences in formate. Formate is toxic in the brain because it's a metabolite caused by the degradation of the ethanol, and this causes alterations in the brain. Anti-aspartate, that is a metabolite that has been related a lot with the dementia in the brain. Okay, then it demonstrates that managing maybe the phenotypes in the heart, we can to see what happened in the brain and vice versa. Then, okay, we have these two phenotypes of heart, two phenotypes on brain. What happens if we mix the patients and the phenotypes? We found this. We have made, in fact, we need 4 phenotypes, but only we found 3 phenotypes. And these phenotypes is the brain health, the myocardium health. The brain health, myocardium with insulin resistant. Myocardium with insulin resistant and brain with insulin resistant. And then this is a graphic. And then after having this, we would like to know if OMA or again, the insulin sensitivity index can be useful for managing this patient. As you can see here, again, the normal, despite the P is good, but if you see this graph, it's impossible to split patients to manage brain insulin resistant and this phenotype with the normal clinical daily use of this index. Other things is with this index. But what happened? When the myocardium is resistant, you can to differentiate these patients. Then, also, we would like to check what is the differences again in these 3 groups of patients. Again, this is another very interesting data because this is simple because it's the distribution of erythrocytes, the shape of these red blood cells. Again, enzymes, liver enzymes. Again, as you can see here, this protein that is related with the dementia. Also, index of insulin, systemic index of insulin resistance, and metabolites related with the cognitive decline and cardiovascular risk. Then, as a summary of this part, we observe this. This study was the first to provide evidence supporting the existence of the brain-heart axis in terms of insulin resistance in type 2 diabetes. We have been the chance to identify 3 phenotypes. The absence of these phenotypes is in a brain with risk and a good and a healthy myocardium seems or suggests that the problem don't begin in the brain, start in the heart, and then the problem of the heart is transferred to the brain. The metabolic alterations cause in the glucose in the myocardium. First, cause a problem in the myocardium, and later these problems are transferred to the brain. Sorry. And bueno, there are a coincidence of different phenotypes. Let's talk about this brain-liver axis is very important because, as you can see, in always we have been identification of the transaminases in the phenotypes. Okay. This is another study that we determine the phenotypes in the liver. Here you can see also two behaviors of the type 2 diabetes population. One with insulin resistant, and then the uptake of the liver increased, but for inflammation, and the other is reduced. Why reduced? Because the liver don't have insulin resistant, and then this glucose is uptaken by other organs. Also, the size of the liver, you can see here, okay, the size is higher here. Then we identified these two new phenotypes. Again, we have these two phenotypes in the brain, and then our question: exists any connection in terms of insulin resistance between the brain and the liver? Okay. Again, we perform this type of analysis between the uptake in the brain with the liver, and we observe again this graph, this association, and a different behavior depending on the brain phenotype of the patients. Again, we split the uptake of the glucose in the brain or in the liver by each phenotypes, and we observe again a good differences on the glucose uptake. Again, we determine different liver factors, showing that these both phenotypes can be affected by the fat score, the transaminases, fibrosis. It's like fibrosis in the liver cause a high impact in the brain, and also enzymes. What happened with the cardiovascular? No, when we split cognitive decline risk factor. When we split the patient by the two phenotypes of liver that we have, what observe? Also, we observe an alteration of these proteins that is related with the cognitive decline, and also another metabolites that have been related a lot with the cognitive decline in patients. Again, when we mix all the patients that we have, taking into account the patients, we obtain the relationship. We don't have patients with a good healthy in the liver and good healthy in the brain. However, again, we have a group of patients with no risk in the brain, but risk in the liver. The risk in the liver, no risk in the liver and no risk in the brain. In the brain, problems in the liver, no problem in the brain, and problem in the brain and problem in the liver. Okay, risk. Again, we observe a graphic similar to the previous one, and also this is the characteristics of these patients. Again, here also in these three phenotypes, also you can, despite it's not significant, show the numbers. The adiponectin also is a reduction of the adiponectin that has been related also with cognitive decline in Alzheimer's disease, OMA, blah, 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 blah. Okay, no, because the time is... Okay, the summary of this part is this, okay? We have been, for the first time, the evidence of a liver-brain axis in type 2 diabetes in terms of insulin resistance. We identified these three phenotypes. The absence of these phenotypes said that first, all occur in the liver, and later, these metabolic problems in the liver affect to the brain, cause insulin resistance, and then the risk that I show you during this presentation. This is the last slide because we haven't finished this now, but now we are studying this axis, the brain, liver, and heart axis. This is only the slide that I would like to show you. Okay, we observe different population, but we simplify in three: is mixed insulin resistant, fixed insulin resistant, full insulin resistant. Now we would like to determine the treatments. What is the best treatment to treat these patients? For example, for insulin, is preferred for non-mixed phenotypes. GLP-1 agonist metformin for mixed and full insulin resistant. Blah blah blah. And then also, we analyze the order of affectation in our body. The first study in terms of insulin resistance in type 2 diabetes. Initially, this insulin resistance start in the heart. Then, this metabolic alteration in the heart affect the liver and start the insulin resistance in the liver. And then later, this alteration in the liver cause the alteration in the brain. This is the pathological pathway that we are unraveling just now in this moment. And this is the main conclusion of the study that I would like to show you, okay? There are two brain phenotypes as that can coincide with the heart and the liver phenotypes. We have been the possibility, this is the most important one, to build up a mathematical equation in order to validate in retrospective data. We have also, we know that all start in the heart. The problem in the insulin resistance begins in the heart, affecting the liver, and in the last term, the brain. And also this phenotypic implementation, we would like to phenotype this phenotyping implementation to implement in clinical practice, in clinical practice to contribute to the precision medicine and the personalized medicine of these patients. However, this data is from 42 patients. Then this observation requires validation with large cohort, etc., etc. However, this is the first stone that start to study the phenotyping in type 2 diabetes. But this is my group, okay? And that's all. I have more information, but...
Yeah, we have, probably you have on slides, but we have 5 minutes for questions, and the best part of these seminars is also the discussion. So,
Perfect.
Thank you, Raúl, for this wonderful presentation and very interesting data. So you referred to these brain phenotypes as, well, phenotypes. And so when I think about phenotype, I think about different types of disease, right? And I wonder what makes you think that these could be different types of disease rather than different degrees of severity of type 2 diabetes. You know, I imagine type 2 diabetes to exist on a spectrum of insulin resistance. And you also like point to a possible sequence from heart to liver to brain. So maybe it's just not so progressed type 2 diabetes that it has already gotten to the brain, right? And that's why it would be different degrees of disease severity. So rather than if it was phenotypes, then you would expect to have like different well, disease parameters altered differentially. So are there any, I guess my question is, are there any disease parameters, risk factors that are more abnormal in the hypermetabolic brain phenotype than in the other one? Or are all these parameters more bad in the hypermetabolic phenotype? That would argue for being, well, instead of a phenotype, more like a different degree of disease severity, which is not less important.
Thank you very much. I agree with you that I told phenotype because it's two within the same pathology, two behaviors, two different behaviors. Then at that term, I think the term phenotype is well recognized. Okay, in this term. Okay, however, in terms of classification of patients or the difference about the phenotypes, we only observe an evolution. If you take all our data, the evolution is more metabolic disease because the OMA, the insulin resistance is higher in this patient. Then it's growing. Also, we have an alteration of fatty acids because we observing as adiponectin, free fatty acid, blah, 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 is growing. Then at that way, is a discussion. This is a phenotype of a classification of patients. Okay, I'm not sure. I'm not sure if it's a classification or a phenotyping. Here we have a clear point that the most important one is all these patients was include in the clinics with similar behavior. They don't have cardiovascular and a controlled type 2 diabetes, normal population. Then these two classification of phenotypes exist. If these patients go to the endocrine, they are going to treat in the same manner, one and the other. This is the problem. The problem is you can attend in the same way patients with one risk with the other one. But in the clinics, they don't have any index. They don't have anything to personalize this in patients. Then, is it a classification? Could be. But in this classification, we need to select what of these patients are more risky. Because here open other things. What happens if you the patients that have been with statins and preserve, for example, the uptake in the myocardium? What happens with these patients? They also cause dementia or not? Or the average of dementia in this population is lower than the other? Anybody knows? Then I think you need to take our data as a classification or a phenotype, whatever you want, but it's clear that we have here a problem. We have two different phenotypes, two different classifications, and we need to identify these patients. And the difference is in blood, as you can see in the biochemical data, in all this data. I don't know if I answer you.
I think but sounds like you are also think more of these phenotypes more like on a more severe disease rather than
Could be. In fact, if you observe this patient, and progress. It's more
from the heart to the liver. Now it's in the brain already in some of them and not in others.
But
why they have a higher.
But here the point is how you know the patient in what the status is in order to get
the HOMA score doesn't give you this detailed information on disease severity, to say it like that, right?
Depend.
At least it
Yeah.
reflect well these types of
severity
if you define
here yes, but here yes, but here that is only if you get the phenotypes in the brain. Also, you can define this. But what is the threshold? This is the point.
Measure severity complementing.
Yeah.
Classic HOMA scores.
Yeah.
Maybe you already asked for that, but a couple of questions regarding the cohort. The average age of these patients?
Here.
66
and 68.
And do you have cognitive information of them?
Yes, bueno, the cognitive information of these patients is a medimental test, okay, and also was include the patients that are higher than 25 in the scale of 30 to 25.
You don't see difference
No,
between
no,
groups in terms
no,
of
no, no,
cognitive.
no. But I have this data. Maybe it's a good opportunity to put in this table. Yeah.
And Alzheimer disease biomarker, do you have?
No, I don't have this problem. That way, I say, Jesus, please, I would like to know more in detail because I have the plasma of these patients. I would like to analyze because this is the only protein that has been described.
This is not
No,
really
no,
a
no.
biomarker.
Yeah, yeah, yeah.
I thought in the beginning, if you can put the hyper and hypometabolism scores, so the patterns of the hyper and hypometabolism groups. The pattern in the so my main interest in this work is I play with a bit of advantage here because I was in the PhD committee of Herald who did most of this work, so this worked very well. But the pattern in the hypometabolic group looks very AD-like. So I was very interested in performing AD biomarkers in these subgroups. It was also very interesting. I don't know if you, so this clamp methodology is a bit complicated, but actually what this means that is showing in the hypometabolic pattern is that this deficit in glucose was corrected with the clamp. And I think this is very interesting because I would take like Alzheimer's disease patients with type 2 diabetes and try the clamp in them. Maybe we will see.
Yeah. It's
Probably you mentioned the PESA study, the one of Valentin Fuster,
Yeah.
Cuando
Yeah.
Gisper was involved,
Yeah.
and you know that they found a similar pattern in
Yeah.
young individuals with a lot of cardiovascular risk and
Yeah.
sclerosis. They found a similar
Yeah.
pattern that they are trying to further characterize.
Yeah, but
they found it also. I don't know if diabetes was included in that phenotype. They were focused on arteriosclerosis.
I
Probably it was.
yeah.
They were younger. Yes.
Yes. But here the point is to, despite Juan do Valentín doing this study, okay, they never use the clamp. Then they don't have information. They have information about the uptake of the glucose, but they don't have information if this uptake of glucose, the loss of this uptake or the increase of this uptake comes from the insulin resistant or no. In fact, the point here is in the literature, everybody talks about type 3 diabetes because if you put in Google type 3 diabetes, you have a lot, Nature's, everything. Okay, JAMA, you have a lot of paper. But nobody never have determined this in the brain. Only Nati, that is in Finland, they use an approach with the kinetics that I commented you before. And also they observe the defects. They observe defects in the brain also. But this is the first time that you can to measure exactly the insulin resistance. Then at that way, I think this is our goal, is to set up equations, mathematical equations like this, okay, in order to follow simply the patients. Because you need to take into account that all the studies that we are performing in a hospital needs to be relational in order that the patients arrive our research is non-basic. We need to develop this type of functions to perform apps, whatever, because in fact, in the end, we would like to draw an app and a type 2 diabetes app where the endocrinologist or any doctor plays the biochemical data and then said, okay, this patient has probably this number of insulin resistant in the brain, and this means that maybe it's causing a risk of dementia. Please follow this patient in the heart, in the liver, in the lung, whatever, in any organ, okay? Here I show you the brain, but we have data about lungs, skeletal muscle, myocardium, gut microbiota. We have like an a pig. We obtain information of all the parts of the body, okay? Then this is very important in order to draw what and a clinical decision support system for clinicians. Ooh.
Between the organs, so you are probably very well aware that there may be a stealing effect in place. So when you declamp, if the liver suddenly uptakes a lot more FDG, then by nature there will be less FDG available for the rest of the organs. And this is observed, for example, this is why patients cannot run before doing an FD pen, because if not, all the FDG will go to the muscles and we will not see anything in the rest of the
body.
Yeah. So these relations, for example, between the liver is very, very big organ. So if after the clamp, the liver uptakes suddenly a lot, it will just be by that there will be less FDG available to go to the brain. So these inverse relations
Okay.
almost natural. So I wonder how you treated this in your analysis of the.
Yeah, of course, I fully agree with you that is in the end, you have this glucose and you need to distribute this glucose in the body, okay? If you have more resistance, for example, in other organ, the liver can uptake more, okay? Because it's concentrated the glucose just there. But if not, it's going to
I wonder that it would be nice to have dynamic bed of these patients.
Yes, the problem, okay, also I think so. But the problem is when you use a clinical scanner, where a lot of people are waiting for an attack. This isn't a problem in doing research in the hospitals, because we have in Vall, just now we have 2 PET CTs. Now we are going to have 4 in 2 years, 4 PET CT. But despite this, we are performing around for each PET 5,000 patients per year. Maybe we have a large list of waiting lists. Then I need to put this in like an other patient, similar to other patient. But I fully agree that if we have dynamic data, we will have more information because we have all the kinetic information, plus the clamp, plus all the things that we have been observing just in this presentation. This is the point.
Last chance to ask any question. If no, we can thank again Raúl. Say bye bye.
Bye. Gracias.